Rehabilitation strategies in spinal cord injury, a clinical review. Dr. Goldstein, thanks.
Well, thank you very much. This is quite a change in topic, change in gears here, and we'll review in the next few minutes the last 55 years or so of rehabilitation. And there wasn't much rehabilitation prior to World War II. I think it's important to look back and to remember how recent these changes are in history. It's because people almost uniformly died in the Balkan Wars, in the beginning of the 20th century, as well as in World War I. People died before they were shipped home. People died invariably within the first year if they had a neurogenic bladder from urosepsis. There were no antibiotics. There weren't the medical advances that were really required for people to survive. That changed very dramatically in the 1940s and the 1950s, and that was primarily from World War II and the polio epidemic. In the United States alone, you had, after great advances, many people returning who previously wouldn't survived. This is primarily because of the advances in blood transfusions, antibiotics, as well as surgical and anesthetic techniques. In fact, there were over 2,500 paraplegics that returned stateside, and what's really interesting about that is after such poor survival throughout history, there were 75% of these individuals alive 20 years later. Now that is remarkable also because these people were told you should pull your affairs in order because survival is unlikely, and they just kept on going. These people stayed in the hospital. In fact, it was also interesting that finally, over time, when they got out of the hospital, over half of them returned to the workforce. Polio was no different. In 1952, for example, there were over 58,000 people with polio. Many of those had severe disabilities, and the question was, now what? What happens to these people? So there was remarkable increases in survival over the past 50 to 60 years. And as survival improved, there was a shift in thinking in medicine and in society, from rather taking care of these people and treating the many medical problems that came in. The first thing that people started talking about was physical rehabilitation. Over the next 25, 35 years then, there was a focus on independent living in the community. That was new. That led to basic civil rights movements in the disabled community, and so it goes. And then finally, today, we talk about aging with a spinal cord injury as people live into their 50s, 60s, 70s, and beyond, and live very healthy lives. So let's look back. What in physical rehabilitation was happening in those early years? Because with physical rehabilitation, in the 1940s and 50s, people stayed in the hospital for a couple, 3 years. All the natural recovery that was going to occur occurred while they were engaged in therapy. And there are some remarkable stories documented through the Paralyzed Veterans Association of what was going on in the hospitals at the time. Also, they were learning, as now, how to do things when things didn't recover. So what sorts of strategies and behaviors are needed to do things for mobility, dressing, to get maximally independent. And there have been many reviews all over the years, not very many clinical trials. It's felt to be unethical to withhold these sorts of treatments, but certainly there have been many reviews and evaluations that these strategies work. It's interesting now that rehabilitation services are being cut more and more. We are reinventing old controversies where people were very independent and able to do things. It's not sexy, it's not glamorous at all. It doesn't sound great like stem cells, but we discharge people all the time now who can't get off the floor back into their wheelchair. There's just no time. They fall out of their wheelchair and call 911. It just makes no sense in terms of using resources. You've heard today, you live in your lives, hearing about search for a cure and search for improvement in physical recovery, and that's not what I'm going to talk about. Certainly, in the 20th century, the early part of the 20th century, there was a very static view of what happened in the nervous system after injury. There wasn't a good appreciation of plasticity. Ramon Cajal and others painted a view, once those nerve cells die, they're dead. Then over the last 40 to 50 years, we've had a great appreciation for plasticity in the brain and the spinal cord, and more importantly, that the plasticity responds to input, all kinds of input, including sensory input and learning. This has given rise to and greatly affected rehabilitation, especially in the ways of activity-based therapies. This is very hot now. People are talking about activity-based therapies, and basically what you're doing is repetition and retraining to stimulate and use new circuits that are developed. It's easy to think about in terms of repetition and practice, incorporating the descending fibers that are still intact, the supraspinal fibers, as well as the afferent fibers coming in on a reflex level, and that gives improved motor output. And this dates back, especially in terms of locomotor training. I mean, people use this for hand therapy, for locomotor training, as well as other muscle groups. This has been evaluated in cats, many other animals, observations in humans. It's well accepted in neurobiology that plasticity occurs, that locomotor retraining is possible, especially after incomplete injuries, but curious that only over the last few years have we looked at this in any sort of rigorous and experimental way. And thinking about repetition and plasticity in getting people into a pool, in parallel bars, over ground, inside and outside, and the latest craze is using all kinds of equipment. In that upper, your left corner, that costs about $270,000. That's a European-made, weight-supported harness and treadmill. So some of these things get pretty pricey. And yet the controversies remain. What works? And that's what patients are asking us. When all is said and done, surgery's done, there's medical stability, how can I get better? And I think we're obligated to try to answer those questions. And more specifically, is weight-supported treadmill training better than conventional training? Just as an example of the types of controversies and questions that remain. Bruce Dobkin and his group, along with several centers in the United States, addressed this question. They basically took, and this was the first well-designed, randomized, single-blinded rehab trial for incomplete injuries. They took incomplete injuries within 8 weeks of injury and who were not ambulatory, randomized them into either treadmill training or conventional overground training. 2 important points with this trial, and it was published about 1.5 years ago. First, the interventions were of equal intensity. With so many of the convenience samples and trials that you see out there, the intensity is different. So they worked very hard to get intensities in the 2 arms the same. And the second, and it's really a proof of principle issue, they took the highest intensity and they said, this either works or it doesn't. If it doesn't, we're off base with our usual rehab programs. The results were great, and in fact, most people achieved good walking, reasonable speeds, in fact, surprisingly good speeds, good endurance, and excellent balance. In terms of which group did better, they both did the same. But what's been lost in the debate and the discussion is how much better the outcomes were than everything previously reported, especially for the ASIA C and D injuries. In the ASIA C and D injuries, they had remarkable results that have never been seen before, and it's probably from the, not probably, it's from the intensity of training that they saw. Unfortunately, with the ASIA B injuries, if they didn't quickly convert to a C, they had a relatively poor outcome. About 1/3 of them became community ambulators. So these are the results for community ambulation 6 months later, and looks great for Asia C and D injury. So to me, this is not a big head-scratching moment. Rather, we should be advocating for vigorous acute rehabilitation beyond what we provide throughout, at least in this country, to enhance activity-dependent plasticity in the spinal cord. So, is this rocket science in terms of rehabilitation? And I want to step back and offer the view that the rest is rocket science. And what is beyond walking and hand function? People with spinal cord injuries over the years and decades have been asked, what's important to you? What are your own goals and aspirations and dreams? And no surprise, it's similar to everybody else's. After that acute period and recovery, people focus on the same things in terms of self-directed lifestyles, independence, work with meaning. That's really critical. Work with meaning. That gives their life meaning. Recreation, fun, buying things. You know, they want the same things everybody else does, because the only thing that's different is their spinal cord doesn't work. And now, thinking about aging with family around, it's the same. Christopher Reeve, in his book, did say, we are so much more than our bodies. But remember, what most people think of with Christopher Reeve is his big push to walk. As time went on, as with everyone, other things become important. Now, don't get me wrong, I am a fierce advocate for physical rehabilitation. And I think it's important for all of us who are clinicians to continue to advocate for physical rehabilitation. But rather, when thinking about quality of life, the tighter correlations are with these broader life issues, and that includes work, play, and some of the other things that I've been mentioning. So, a critical review in terms of rehabilitation, we need to reinvigorate and continue a multidisciplinary rehabilitation process, because it's really hard to do everything in front of you. New information's required, new skills, there are new barriers, risks, new challenges, and new losses. This is tough stuff. This is a really hard thing to do to get through this period and then resume a life that has meaning and has high quality. We also need to recognize that times are changing, and they're changing fast. Rehabilitation coverage is being cut on inpatient and outpatient, so we need to start asking the questions in a more rigorous way: how much, what specific type, and when? Look at this. This really underscores the point. In the model systems in the United States, one of two of the biggest systems that follow people with spinal cord injuries, acute care, those are averages in days. In the 1970s to now, have slowly drifted down to about 20 days. Look at rehab. Less than half the time is spent in inpatient rehab, and nobody has really studied what that means. We know what it means, those of us in outpatient, because we see people. And remember, with these means, 45 days, for example, embedded in that are some people with simple paraplegia, where they get out of acute care, get into rehab, and 3 weeks later they're home. That's a remarkable fast turnaround to incorporate all of those changes and new behaviors. We know the consequences. People are sicker, there's less time for rehab, there's less time for learning and adaptation, and there's a big shift over to outpatient while outpatient services are being cut. It makes no sense. It's insane. And another not too subtle point is people go back to their community, and are there people who have any spinal cord expertise? I'll give you two examples that have just come up in the last few months. One was a C7 tetraplegic from Eastern Washington, went home, wasn't followed up for 5 years, had great care, actually, from a PCP, came back. He was so weak. This is a man with C7 quadriplegia. Transfers himself, pushes a manual wheelchair. This guy couldn't do any of that. And he had gained over 100 pounds. Put somebody in a power wheelchair. What do you all tell people after they're injured? Same thing we tell them in acute rehab. Eat. Nutrition is important. They go home, still everybody's telling them to eat, and they gain tremendous weight. Or we saw a 42-year-old guy. He had been walking for 18 months with a very well-meaning therapist. He did not have anti-gravity quads, he didn't have anti-gravity glutes, and he had totally trashed his knees. I don't care if a cure is found tomorrow. We did this man no justice, so some of this doesn't make sense. And finally, in terms of consequences, is we're discharging more and more people to nursing homes. Less people are being discharged to their home. Now, there is data. After 5 years, the rates are about the same. But what happens in the nursing homes in the meantime? It's really horrendous. And we know we go out to those nursing homes. So where are we now? And just wrapping up what I see as important, we need to use the evidence that's available. The clinical practice guidelines that are produced by the Consortium for Spinal Cord Medicine should be used by everybody. That's the best evidence that we have now. We need to push for physical rehabilitation, as I mentioned previously. We need to use and push equipment and technology. We also need to use technology to open up people's worlds. We've never lived in a world like today where technology can be used at work and in home. And finally, we need to look at employment and other important domains. Many of you contact us and say, why isn't this person working? If you look at this, we get to about 40% overall. That's not bad. It's not bad, but look how long it takes at the beginning. People just have too much on their plate to be thinking about work in that first year or two. And look also, there's not much of a difference between paraplegia and quadriplegia in terms of return to work rates. We need to be looking at quality of life. We need to get to know our patients for what's important to them, because only then will we be effective in really delivering the rehabilitation that people need. Thank you very much.
And sort of to come full circle, to really find out, since the outcomes in truth are not what we want, it's what our people want, we're going to come full circle here, and we're going to bring another person whose life has been impacted by spinal cord injury. Jim Osborne is director of REI, and a local who has also suffered a spinal cord injury, and he'll close the meeting with his description. Thanks.
It's a pleasure to be here to have a chance to tell you my story, my recovery story from a spinal cord injury. I too am a cyclist. I've had a passion for cycling for many, many years. And in many ways too, it's also defined who I am. In June of '07, I was on a cycling ride with some friends, and a freak thing happened. A stick got kicked up into my front wheel, got locked up in the spokes, and within a nanosecond got wrapped around to the fork, and it sent a catastrophic shock through the frame of the aluminum bike. And the bike fractured right underneath me. And I was basically torpedoed, body slammed head first into the pavement. I suffered hyperflexion of the cervical spine. I had central cord damage. I also had a dissection of my vertebral artery on my right side between C2 and C6. I believe I was admitted as a C7 Asia C tetraplegic. My life from that point forward changed. I was placed in an involuntary position of having to rebuild my life, both emotionally and physically. This is a picture of the bike. When I was an inpatient at Harborview, I had some advice from my doctor, Dr. Chapman, and the two words he spoke to me that really resonated were, get independent. And that really became my beacon, my vector of focus and recovery. Initially, I had very limited movement above my waist. I had a little bit of arm movement, but really no hand movement, and almost no movement in my legs. I took those words and applied them this way, that I would do everything I could to do just simple pedestrian tasks without help. Simple things, whether it was trying to pinch the wrapper off a straw, open a carton of milk, hold a utensil in my hand, open an envelope, I spent hours and hours, days, sometimes weeks, just trying to do those tasks without having to ask for help. And you know what? Those little victories started to add up. And eventually they became bigger victories and bigger victories. And soon I was able to transfer myself from my bed to the wheelchair. And then I was able to stand up in the parallel bars. And not long after that, I was able to shuffle my feet in the handlebars. And not long after that, I was able to get out of the wheelchair. And not long after that, I was able to get out of the walker. And I was just able to use a single prong cane. In fact, when I was discharged from the hospital, I'd had a goal that I wanted to walk around the perimeter of the hospital, all 4 blocks, including that real steep incline by the parking lot. And I did it on my own. I had spotters with me, but I did it on my own without any adaptive devices. My recovery trajectory was very steep, and I had come to understand that a strong recovery begets an even stronger recovery. And as I moved into an outpatient setting, I continued on with PT and OT. I had some other supplemental therapies that I did, massage therapy, acupuncture, reflexology. My recovery continued to be strong. Within 3 or 4 months after the injury, I was able to walk a mile. I was able to walk up and down stairs without any assistance, without even having to hold the railings. And then in the November-December time frame, I hit the wall. Basically, I had a very serious setback. And my tone levels went way up. My pain levels went way up. Where I'd been able to walk a mile just a few short weeks before, I was able to barely walk from the kitchen to the bathroom. And it scared me. I'd had such a strong recovery up to that point, and then all of a sudden I'm seeing myself go backwards. And then fear set in. And then depression set in. I've never been depressed in my life. And it's a scary place. My whole world started to close in around me. I didn't want to move out of the house. I sat in a recliner chair most of the day, and I became a clock watcher. And I just waited for the clock to hit 9 o'clock so I could go to bed and then not have to look forward to getting up the next day. I remember seeing Dr. Goldstein during that time. It was mid-December. And I remember he looked at me in the course of his evaluation, and he said, "Jamie, you just look woofed." I was woofed. He gave me a bunch of prescriptions for medications to deal with depression, to deal with spasticity, to deal with pain. Prior to that point, I'd been on only 2 medications. After that setback, I found myself on 8 medications. I was on methadone, I was on oxycodone, I was on antidepressants, antispasticity pills. And as I got through the first of the year, there were 3 things that I think helped me turn around. Number 1 was the love of my family and my friends. Another reason was that I started to rethink back to the approaches that I had taken early on in my recovery. And thirdly, I started a range of new therapies. PT was certainly central to that. But I realized that my progression was going to be a lot slower. I'd passed that 3 to 6 month time frame where the bulk of recovery typically happens. And my trajectory of recovery has been a lot slower. But I've been in what I would call kind of a retrace period of re-educating my neurosystem. And I'm happy to say that I've been able to recover most of what I was able to do last fall. I can walk a couple of kilometers now in a single spell. But there's things that I can't do now that I could even do in the hospital. I still can't walk up and down stairs without a lot of difficulty. But I'm confident that those will come. So what's reality today for me? This is a cruel injury. Whether you're an incomplete like myself, who has some degree of fine or gross motor function, or you're a complete and you're confined to a wheelchair. This is a crummy injury. There's no way to call it any differently. With an incomplete injury, the recovery potential is very, very broad. Some incompletes never get out of a wheelchair. I think that's mostly the exception. And some people make a complete recovery. But my point being is that it's very difficult to predict where I'm going to end up. What kind of sports will I be able to play in the future? Will I be able to run around the court with my daughter? Will I ski again? Will I play golf again? What kind of residual deficits am I going to have? I don't know, and my practitioners can't tell me for sure. They can quote population studies and say, this is where general population trends take you. But that doesn't tell me exactly what's going on. I had a visit with a practitioner, a nurse practitioner, last fall because I was starting to experience extensor cramps at night where my body would just shoot out in spasticity with even just the slightest motion. And I remember she said to me these two words about, well, it's part of the neurological progression. Well, I have to tell you from a patient's perspective, those are probably the two most unrewarding words you could possibly say because they mean nothing to me. What it did tell me is that the healing process is not linear. There are undulations in the recovery process, and I was experiencing them. Another thing that I deal with is fear. I'm not a fearful person by nature, but I do fear crashing again. I crashed back in November and December, and I still have that little whisper in the back of my head about possibly crashing again. I'm always conscious of every step I take. Will I fall? What if I'm in a car and I get rear-ended? My poor wife and daughter were rear-ended just a few weeks ago. What if I'd been in the car? And I'm getting counseling for those kinds of things to help deal with that fear. The final point I want to make here is about identity. For me, sports, athletics, fitness was how I defined myself. I've been an athlete for 35 years. And now, I don't have that as a hobby, as a thing to do, as a thing to get back to. And I'm trying to rediscover what's going to fulfill me, what's going to bring me meaning, what's going to bring me satisfaction and value in my life. I will say there are things that I can do which are great. I can drive, I can write, I'm back to work part-time. And the last slide I'd like to show you is a picture that was taken just a few short weeks ago. I came back home and told my wife I was ready to try and get on the bike and just see if I could balance it myself. I just felt in my head that I could balance it, and I'd been able to move my legs on the stationary bike, and lo and behold was able to do it. You can see the concern on her face. I'm smiling big time. So I want to thank you for indulging me today. Thanks very much.